I now invite Dr. Rashmin Gandhi to speak to us on visual fields and localizing the lesion. Again, something as neuro-ophthalmologists where we have to, work as detectives to be able to locate that.
Thank you. Thank you so much. Thank you, Digvijay, for inviting me for this session. So, there are a few disclaimers. One, neurological visual fields ideally should be tested on a kinetic perimetry, but they are not very popular, not readily available. Confrontation test is something which we should all know and deploy even in our general ophthalmology practice, because it can really screen out the serious problems, and that's something which Ankur already spoke about. So I'll restrict my talk to the automated static perimetry. So if you encounter a visual field like this, it's actually not very difficult. The first thing you look for is, are you able to see blind spot? Because that will give you a clue, if you're not really very familiar, to say whether this is a temporal defect or a nasal defect. And you see very clearly that there is no blind spot on either side. So telling you that this is bitemporal hemianopia, a very clear-cut case of a bitemporal hemianopia. You know that this is a neurological visual field defect, and you localize the lesion to optic chiasm. But it's not always, and this patient actually had this pituitary lesion, but it's not always that we encounter such clear-cut cases. This is what we will see in our day-to-day OPD. So now here we have a patient who has this kind of visual field defect. Now let's look at the left eye. You see the left eye is a complete generalized reduction of sensitivity of the left eye. So this is something which will happen in an optic nerve lesion. So if you find a unilateral region where you have this kind of problem, you know that that optic nerve has a very severe or profound visual impairment. Now couple it with, so this is a blind spot here. So couple it with a supratemporal defect in the other eye. This again is a sign of a chiasmal lesion. This is called junctional scotoma, an optic nerve lesion in one side and a supratemporal lesion in the other side. So this is again a feature of optic chiasmal lesion. We go a little further and say that can you localize it even more, and what we are dealing with here. Again, you look at the left eye has been very helpful by becoming completely hemianopic. So there is a complete hemianopia of the left side. You know that. So you know that you probably are dealing with a chiasmal problem. But how does the right eye give you a clue? So here you have a lesion here which is on the nasal side and a temporal side in the inferior part. So what now you know is that there is a complete temporal defect in the left side, inferior temporal defect of the right side. So you know that you have a chiasmal problem which is coming from above, because when you have a predominant inferior defect of one side, you know that the chiasm is being compressed from above. So that's one first information that we got. Chiasmal lesion which is above. How do we fit in this? So this is like an arcuate defect. So arcuate defect also is a sign of an optic nerve lesion. So now you know that there is a bitemporal defect, chiasm being compressed from above, and because the right side optic nerve also is showing extra defect, you know that that particular lesion is also veering towards the right optic nerve. So the bitemporal chiasmal problem with a lesion going towards the optic nerve is how you will localize lesion just by looking at the fields. However, one has to remember that bitemporal hemianopia is not always neurological. There are, or it's not always compressive. There are lesions like this which can give you a visual field defect which may appear predominantly bitemporal, like tilted optic disc, nutritional optic neuropathy, especially optic neuropathy, can present with bitemporal defect. Enlarged blind spot sometimes can be confused with bitemporal defect, or RP initially can have a predominant temporal defect. Contrast it with this. Here you are able to see the blind spot. So though this field appears like a complete hemianopic defect, but this is a binasal hemianopia. And when you have a patient with binasal hemianopia, what you are looking at predominantly is an ocular cause or a problem within the eyeball. It's very rare for an intracranial cause to cause a clear-cut binasal hemianopia. So that's about the chiasmal lesion, because that's something which is often missed or misdiagnosed with NTG, optic neuritis and whatnot. And a problem can be treated if there is a chiasmal problem, and you can effectively save the patient's vision. Now we move on to the second scenario. You see here a patient who has a predominant inferior defect. So this is inferior altitudinal defect, and your diagnosis would be AION. AION generally causes because it's a vascular event and it follows the vascular pattern of the optic nerve, blood supply to the optic nerve. So it causes an altitudinal defect. Inferior altitudinal defect is much more common than the superior altitudinal defect. What about here? You see, so first of all, if you have a visual field isolated, you know that this is a supronasal defect, like an arcuate field defect. But always remember that the visual field can also mimic anything which is happening in the eye. This patient actually had a branch retinal artery occlusion. We move on and say, okay, this is another example of a visual field defect where there is a visual field problem in both the eyes, which is respecting, by and large, respecting vertical midline. Please remember, in glaucoma, we look at very specific changes and then look at mean deviation and pattern standard deviation, because that's what will guide us for the treatment. While in neurology, we are only looking at the patterns, because that's what will localize the lesion. So here what you're seeing is that there is a left-sided defect which is predominant inferior. So this is left homonymous inferior quadrantenopia. You're looking at mainly, so this is what is also described as pie in the floor. So generally the lesion would be in the parietal lesion, a parietal area, versus here what is described as pie in the sky. So you see this is a predominant left-sided lesion, superior quadrantenopia. Here you're looking at temporal lobe. So if you have a homonymous defect, that is one side of the field is affected in both the eyes, and if it's inferior, you're looking at parietal lobe. If it's superior, you're looking at temporal lobe. Any idea what we are dealing with here? Looks overall okay, but what do you think? So you see here, these are blind spots which are slightly enlarged. So this is a sign of an acute papilloedema. Generally, enlarged blind spot occurs in an acute papilloedema. So you have a optic disc which is questionable or which is swollen, and if you see this kind of picture, you know that maybe you are dealing with papilloedema, as what Rohit discussed. What about here? This is a very specific pattern. These are more important. I mean, they are rare, but they are more important, especially for residents or fellows who are going to write the exam. So these are the kind of defects. This is called sectoranopia, and this is generally a sign of a problem in lateral geniculate body. You can either have a defect like this, or only these two triangles can be affected. Again, because of the blood supply, the way LGB is supplied. What about here? So you have, if you just look at this, you know that there is a right superior quadrantenopia, and then if you only look at this, you know that there is a left inferior quadrantenopia. So basically, patient had a stroke on both the sides. So where the superior one, so right superior, so patient had a left temporal problem, and the left inferior patient had a right parietal problem. So to conclude, whenever you're looking at the visual fields, the first thing to do is to have both visual fields together. Placement of the visual chart is very important. The right visual field should be on your right side and left visual field should be on your left side. Look at the gray scale first, because that pattern will tell you whether is there any particular pattern that you are able to see, which immediately gives you a diagnosis. A mean deviation sometimes can be important, especially when you are following up a patient, when you have done a serial visual fields, and if you see a clear change in mean deviation, whether it's improving or deteriorating, mean deviation can give you a clue. Once you have placed the visual fields, first question you ask yourself is visual field defect monocular or binocular? Monocular is much more likely to be retina, optic nerve, or very rarely cortex. Binocular, you're looking at chiasm, where temporal visual fields will gone, and post-chiasmal, where a homonymous hemianopia, that means a visual field temporal side of one side and nasal of the other side, is generally involved. Thank you.
Thank you, Dr. Rashmin. Your presentations are always pretty thought-provoking. I enjoyed one of those that you had at that PG